everyone, welcome to Dr. Sravani's Med Concepts. In this session, we'll explore sclerosing adenosis, a benign lesion which closely mimics invasive carcinoma and hence is diagnostically challenging. As per WHO classification 5th edition, under epithelial tumors of the breast, we have separate entity known as adenosis and benign sclerosing lesions, as we have already dealt in the previous session. Under this, we have in adenosis, we have sclerosing adenosis, apocrine adenosis and adenoma, and microglandular adenosis. And in benign sclerosing lesions, we'll have radial scar and complex sclerosing lesion. Today, our discussion will be on sclerosing adenosis. Coming in detail about sclerosing adenosis, what is sclerosing adenosis? It is a lobulocentric proliferation of benign glandular structures which are distorted by fibrosis. It has 1.5 to 2-fold increased risk of developing subsequent breast cancer. So this is a diagram showing sclerosing adenosis. What is the origin? It arises from the terminal duct lobular unit and the architecture is lobulocentric. There is proliferation of acini within the lobules. It causes enlarged lobular unit. Despite the proliferation, the overall lobular configuration remains intact and hence it is known as lobulocentric pattern of growth. So, lobulocentric growth pattern is best appreciated under low power. Coming to the glandular component, in sclerosing adenosis, acini are increased in number and often appear crowded and infiltrative, which mimics carcinoma. These glands are dilated at the periphery and compressed at the center. Cellular lining, acini are lined by two cell layers, inner luminal epithelial cells and outer myoepithelial cells. The inner luminal epithelial cells are cuboidal to columnar with centrally located nuclei, and myoepithelial cells are flattened or clear cells which are retained around the acini, distinguishing sclerosing adenosis from invasive carcinoma. And there will be sclerotic stroma. So there is prominent stromal sclerosis with dense collagen deposition and which may entrap glands, creating a pseudo-infiltrative pattern, because of which also it mimics carcinoma. This sclerotic stroma is more pronounced in the center of the lesion, and calcifications may be present and can be detected on mammography. This is another picture showing sclerosing adenosis. So there is proliferation of acini within the lobule causing enlarged lobular unit, as we can see here, and the lobular architecture is preserved. So lobulocentric growth pattern which is best appreciated under low power. Here we can see the acini are lined by double cell layer, that is dual cell layer, inner luminal epithelial cells and outer myoepithelial cells which are flattened or clear, and there will be sclerotic stroma. Sclerosing adenosis is immunostained for smooth muscle, myosin heavy chain, P63, etc., highlighting the myoepithelial cells around the glands. Here in this picture, we are able to see the IHC for smooth muscle, myosin heavy chain, which is highlighting at the periphery of the acini, that is the myoepithelial cell. Coming to the differences between sclerosing adenosis and invasive duct cell carcinoma, sclerosing adenosis is a benign proliferative lesion, whereas invasive duct cell carcinoma is a malignant lesion, and the sclerosing adenosis shows lobulocentric proliferation with distorted acini, and invasive duct cell carcinoma shows infiltrative pattern. The stroma is dense sclerotic, often hyalinized in sclerosing adenosis, and it is desmoplastic, and reactive stroma is seen in invasive duct cell carcinoma. Cellular atypia, it can be minimal atypia or absent atypia in sclerosing adenosis, and there is marked to moderate atypia in invasive duct cell carcinoma. Myoepithelial cells are intact in sclerosing adenosis, which are highlighted by P63, SMA, and smooth muscle myosin heavy chain. They are absent in case of invasive duct cell carcinoma, and hence there is loss of myoepithelial markers in case of invasive duct cell carcinoma. In IHC, as the myoepithelial cell layer is intact, it is positive for P63, SMA, calponin. In invasive duct cell carcinoma, myoepithelial cell layer is absent, only luminal cells are present. They are positive for ER, PR, and HER2 variable positivity will be seen, and Ki67 is increased expression is seen. Radiologically, sclerosing adenosis can mimic carcinoma on mammogram or ultrasound due to distortion of the acini, and in invasive ductal carcinoma, mass is seen with spiculated margins and calcifications. Clinical behavior: sclerosing adenosis is a non-neoplastic lesion and it cannot metastasize, whereas invasive ductal carcinoma is invasive and it has potential for metastasis. In the management, sclerosing adenosis is managed conservatively and it may need biopsy for confirmation, whereas IDC is treated by surgical excision with or without adjuvant chemotherapy and radiotherapy. Comparing the histopathological differences between sclerosing adenosis and invasive ductal carcinoma, in sclerosing adenosis, there will be lobulocentric architecture, no cytological or minimal atypia is seen, there will be preserved myoepithelial cell layer, and sclerotic stroma is seen. In invasive ductal carcinoma, as we can see here, there will be infiltrative tubules and nests, there will be marked cytological atypia, and there is absent myoepithelial cell layer, and desmoplastic stroma is seen. In summary, sclerosing adenosis arises from the terminal duct lobular unit. There will be lobulocentric growth pattern which is best appreciated under low power. Acini are increased in number and dilated at the periphery and compressed at the center. Acini are lined by inner luminal epithelial cells and outer myoepithelial cells, which can be demonstrated by smooth muscle myosin heavy chain P63 and calponin. There will be prominent stromal sclerosis entrapping the glands and creating a pseudo-infiltrative pattern which is more pronounced in the center of the lesion, and that's why they have to be differentiated from infiltrative ductal carcinoma. Here we have completed the session on sclerosing adenosis. I hope this session has been useful to you. I request all of you to like, share and subscribe if you think this session has been useful to you. Thank you and meet you with next session.